Hi, welcome to Detours Understanding Acquired Brain Injury, and welcome to the first episode of Seizures, Epilepsy, and Understanding Acquired Brain Injury. So today what we're going to do is we're going to be talking about definitions and how different organizations define seizures and epilepsy, more contemporary definitions, and we'll be also talking about how acquired brain injury may cause seizures as we progress through. So, first of all, most of our research material comes from the International League Against Epilepsy, an international organization that helps seizure patients. That's a group of stakeholders, so patients, families, physicians, researchers, all working together throughout the world in order to defeat epilepsy in the end, to find cures and long-term treatments that are as effective as they can find. We also get information from the American Academy of Neurology, the American College of Neurological Surgeons, the Epilepsy Foundation, and the American Board of Neurologists, and the British Neurological and Epilepsy Organization, and the American Epileptologist Society. So, broad variety of different sources. So, if you have any questions, please, again, comment below. So let's start with some simple questions that people may ask. First of all, like, what is a seizure? And what is epilepsy? Are seizures and epilepsy the same thing? Well, first of all, epilepsy versus seizures. Confusion occurs because the two terms, epilepsy and seizures, may be used interchangeably, even by professionals. And so that leads to confusion for families. And so, what is a seizure? Now, according to the International League Against Epilepsy, a seizure is a temporary occurrence of signs and symptoms caused by abnormal electrochemical activity in the brain. It says a lot without really saying much of anything. So I would say that a seizure is a temporary abnormal pattern of electrical activity in the brain that causes an alteration temporarily in one or more of a person's brain functions. Whether it's motor or sensory, affective, or thinking, and it's due to this temporary change in electrical activity in the brain. That's what a seizure is, essentially. Okay, so what is epilepsy? Now, epilepsy is a brain disorder. So it isn't a seizure, it is a disease or disorder, a chronic condition causing disruption. So specifically, the International League Against Epilepsy says it is a brain disorder that causes a person to be predisposed to having epileptic seizures throughout their life. Okay? Please note that word epileptic seizures, since there are other kinds of seizures, and there are disorders that may include seizures, but these are other conditions, and you need to filter out the mimics, and that's really important too. But we are, with this series of videos, so we are interested in understanding the conditions that cause epileptic seizures, but due to acquired brain injury. Now, obviously, we'll be discussing the treatments and the professionals' help and things you can do, because the seizures have, due to acquired brain injury, have a lot of similarities with epilepsy in general. But we will be focusing a little more on, whether seizures are caused by traumatic brain injury, stroke, cardiac arrest, encephalitis, meningitis. We'll be looking at those kind, but there are a lot of similarities, so it's important to keep that in mind. All right, so what is post-traumatic epilepsy? That's the kind like that I have. So post-traumatic epilepsy is a condition where a person experiences seizures, two or more, that are unprovoked. And this is something important to keep in mind too. Seizures can be triggered by specific external events or situations, or unprovoked, they just happen. at least 1 week after the traumatic brain injury. So what makes it post-traumatic epilepsy is it just happens, it just goes off 1 week after traumatic brain injury. So symptoms may include that you would see staring or unresponsiveness, stiffening of the limbs and or trunk, or shaking, illusions and hallucinations possible across all modalities. So symptom of post-traumatic epilepsy could be they see things, they hear things, they taste things, or smell things. Touch is a little different since, as we had discussed in the past, that the system that regulates touch is a broad band across the brain. So usually, like, tactile hallucinations are less common, but they do happen. Possible aphasia, so sudden loss of speech, the ability to talk, or the ability to understand words, this temporary alteration of the brain. So aphasias, or obviously motor symptoms. They may start picking at things and not respond, or they may start walking around aimlessly. That can be a symptom of post-traumatic epilepsy. Obviously, contributing factors include things like neurotrauma, head injury, a penetrating traumatic brain injury, so a gunshot wound to the head or stabbing increases your chances of having post-traumatic epilepsy. A coma that lasts for longer than 24 hours. So people with moderate to severe brain injury are at a higher risk of having post-traumatic epilepsy. And elevated ICP. Again, those with moderate to severe brain injury who have cerebral edema, elevated ICP. There are other contributory factors: age. Those that are younger than 6 or those that are older than 70 are at a higher risk of post-traumatic epilepsy. Substance abusers. If you sustain your traumatic brain injury while using or misusing substances, illegal substances, or certain medications too, you're at a higher risk. Stimulant abuse, alcohol abuse, nicotine, or narcotics, they do increase to varying degrees your chances of having post-traumatic epilepsy. There are genes that are involved that increase your risks of having post-traumatic epilepsy. GAD1, AD1AR, the ApoE, which is also associated with things like Alzheimer's, is also a gene associated with post-traumatic epilepsy. The interleukin-1B gene and the MTHFR gene is also associated. These genes are all potentially, but these are not exclusively the only genes that may be associated with post-traumatic epilepsy. But knowing a person has these, we know that if they sustain a traumatic brain injury, that their risks are higher. Some of them relate to inflammation, and so generally they may do less well if they sustain a brain injury anyway, but these definitely do have an impact on the severity of their outcome and the likelihood of having post-traumatic epilepsy. We'll discuss more of this later in other episodes, but just to cover this. Post-stroke epilepsy is another kind of acquired epilepsy. That is, you don't have it before, but due to injuries, you develop it. And post-stroke epilepsy is a condition where a person experiences 2 or more seizures that are unprovoked a week after they experience their stroke. And this applies to other conditions like hypoxic, anoxic, post-cardiac arrest, or near drowning, or whatever else. After a week, unprovoked seizures, and it's due to whatever that condition may be. So just keep that in mind. Because obviously during that first week, the entire nervous system is more irritable and more likely to experience. But after a week, then you start to see those changes in the brain start to impact your likelihood of developing seizure disorder. Also, non-epileptic seizures or functional seizures or pseudoseizures, they've been called. This is a complex but separate disorder, and it may resemble epilepsy, which is characterized by that temporary disruption of motor, sensory, emotional, psychiatric function, or a combination of these functions. This disorder, though, is due to a complex and kind of an interactive neuropsychiatric etiology, and it's not necessarily strictly an electrochemical disruption in the brain, although we have found that there are brain changes in people who have non-epileptic seizures or functional seizures. There are changes, but they tend to be much deeper in the brain, and they do tend to have that neuropsychiatric component. So people who've had post-traumatic stress disorder or emotional components, but there's always an interplay between the psychological and the neurological, and that's where the neuropsychiatric comes in. We need you to understand that psychogenic or non-epileptic seizures, the patient is not faking it. They're not. They're not malingering. They're not doing it on purpose. They're not crazy. But they do require different treatments. Anti-epileptic medications and neuromodulators and implants and surgery won't work on these patients. They require different medications. They require different sets, mood stabilizers, antidepressants often, cognitive behavioral therapy can help them, mindfulness, and other treatments. But this is a very complex topic because it involves both neurological and psychiatric treatments. So we are not getting into PNES in this series. This would be something later. If you're interested, do let us know, though, and we will discuss how PNES and ABI are connected, because we do find a higher rate of PNES amongst those with acquired brain injury. And we're not 100% sure why. There are a lot of questions. Finally, when talking about incidence of seizures and epilepsy generally, 50 million, it's about a sixth of the population, have epilepsy, and 50 per 100,000 new cases are identified per year. Almost 2% of Americans are identified as having seizures or had seizures at some point in their lives. About 5 million new cases of epilepsy are diagnosed around the world, and gender does not affect the incidence of seizures in high-income countries. But education does, due to medication compliance issues. So more educated people tend to take their medication as they should, tend to follow through, and so they have better control. And the other factor about that is intellectual disability. People who are diagnosed with what used to be called MR, usually you find that they have familial epilepsy syndrome. So diseases where you have seizures along with a host of other neurodevelopmental problems. And so if you find that, you usually will also find epilepsy-based disorders, where it won't be just seizures that they have a host of other problems, and so that kind of ties in too. So, it complicates matters a bit there, but generally, those are the basic statistics for epilepsy. In general, we will be getting into some of the really basic neuropathology and the etiology, but just for starters, I wanted to touch on that. All right. So as usual, if you have any questions, please below, and please like, share, don't forget the bell icon. If you have any further questions. Hope you found it educational. Please remember, this is not meant to replace your physician or meant to replace your AP or, and if you think you or someone you love is having seizures, please, it's important to get them to the ED, call the EMS number, or contact your physician, because seizures can be life-threatening. Okay, so We will soon be releasing the next episode in our series. And till then, have a good day.